Thank you for that speech, PM. To start the clash for side opposition. Hello, sir here.
Hi, can I confirm that I'm audible and visible?
Yes, you're clear and visible.
Great. Hi, I'm Neo POIs through voice, please. Pronouns for he, him. Hi. Starting my speech in 3, 2, 1. What government needs to realize in the context of this debate is that having more hospitals, period, is not necessarily an a priori good. Just because government has 2 general hospitals doesn't mean you can treat a man with an advanced kidney disease who has spent all of his money and absolutely no doctors can treat them because they're all scattered across the Philippines. We think that those with no alternatives, but to go take the journey to a center are those who we ought to look at and serve the most. If your response is to take down government already. The first thing I want to point out is their odd model. On, if I'm trained as a general practitioner, I can't just be allocated to a kidney center because I'm not trained. So general care will still exist within these hospitals. I think it's very unlikely that governments should just straight up close hospitals to make way for centers. But second, I want to talk about their whole argument on more hospitals equals good because better care. One, I think you're still likely to have a baseline amount of medical care on our side. Wow, that's crazy. What this means is since we have economies of scale and that government, for all the reasons they talk about, proves that general care is popular, the excess budget in the DOH, for example, is likely to go to general care for all the reasons they say. But two, most barangays do not need the LeBron James of hospitals. You see the pharmacist, someone who knows how to treat common diseases, like a local health center, which is relatively cheap, which means that it is likely to be cheap on either side of the house. So even if we don't have big hospitals everywhere, small centers are usually enough and numerous enough that it is generally accessible within the day for a lot of these individuals if they have a disease that they need to get looked at, which already means that it's unlikely for that hospitals in far-flung areas will close. It just doesn't happen in real life. Let's be realistic. A few pieces of setup then. One, what do specialty centers look like? I think, once again, correct. It's hospitals that focus on a specific disease or organ, but the counterfactual and Gov is what I want to point out, is that these centers are non-existent or very sparse for a few reasons. One, it's expensive, as they point out, so it means that there's a huge political will that exists and that will not be met on their side. But what we want to say is that we want more specialty centers, and what we want is different types of the specialty centers. So their side might only have the lung center of the Philippines, but what we want to say is, if I have a kidney disease, that doesn't matter if there's a lung center of the Philippines. We want the kidney center, we want the brain center, and everything like that. Which means that their side of the house is like just does not have coverage for all of these specialized diseases. Two major arguments for this speech then. The first thing I want to point out is why is specialty care of much higher quality, and I'll explain why this is extremely important later. The first thing I want to point out is that access on Gov is not an a priori good. If access to a hospital takes twice as long, or I take twice as long in the hospital because the specialist within that hospital doesn't have the expertise or machinery necessary because it's scattered all throughout the country, then I think that's also bad. Because the thing is that on our side of the house, we get one, economies of scale. It's much easier to concentrate all of the expertise and equipment on both sides, on our side of the house. It's things like vaccines, machines, manpower. I think it's cheaper if you do it in one place. If government says that it's expensive on either side of the house. So if they say that it's expensive and that it's bad, on Gov side, you don't have these vaccines. You don't have any of this equipment, which means that you leave a lot of these people to die. And I think that's really bad. I think the second thing is that teams are just more centralized and cooperative. You get more dedicated care if you do have a serious problem, which means that one, you have a variety of expertise, which means it's easier to solve complications. But second, if you're able to, what happened? Hello? My camera turned off. Hello?
Oh, sorry,
You're
no,
still
just
audible.
sorry. Whoopsies.
Oopsies. Okay, I'll
Sorry.
just continue my
We paused,
speech.
just so we're clear, we paused at 3:07. 3, ayan.
Yeah, okay, I'll continue.
Sorry. Oh wait, Neil, if that does that again, we're not disconnected on my camera.
Yeah,
just
yeah.
kind of bad.
Okay. Where was I again? Easier to. Okay, I just last thing I said was that there's a variety of expertise, and that means it's easier to solve complications. So I'll go from that. 3, 2, 1. But the second thing is just if you're able to expedite the process, there's more manpower dedicated towards that specific organ system, which means there's more protocols towards that specific system, which means that it's just more efficient because you make the entire hospital all about that organ or that disease. Second layer, why is it worse on all Gov? Because one, you have individual hospitals, which means that funding is heavily diluted. Given developing countries being poor, then it's likely that not all hospitals will have facilities for each organ system because it's things like expertise too. You have less people who are expert at that specific thing working working together. You have less things like research exchanges because everyone is so scattered. So if we take government as true, and your kidney doctor does get sent to the kidney institute, that's good because that means that your kidney doctor gets to talk to other kidney doctors and figure out your case. That means that they can go and have the specialist equipment that they need to solve your disease. But second panel, I want you to listen to the analysis from Gov. Note that at no point do they explain how you treat these incredibly sick individuals. And I'm sure DPM will attempt to pivot to that. I don't want to hear them trying to symmetricize this either. But sure, Gov, you get to treat 5 people with simple colds. But screw the guy with advanced lung cancer, right? Screw the guy with a kidney disease that cannot be solved by any general practitioner within the Philippines. I want to point out that these are the people that we want to look at and the people that we have to serve. Maybe people will still have to travel to these specialty centers and it is impacting, but we can guarantee the hospital's ability to treat this better and faster. And note, panel, that there are just some things on either side of the house that are inherent to developing countries that we just can't control. The fact that developing countries are generally lacking in funds, which means we have to be more efficient. So the important impact that we're able to be cost effective insofar as we're able to centralize everyone and make them work together and make sure that we don't scatter it all throughout the country means that we are far more effective and efficient when it comes to treating these as per PM expensive illnesses. The weighing of this is quite simple. One, cost is higher on government, not just for the government, but for the patients. Medicines have to travel, doctors have to travel. For patients, as PM says, they get bounced from hospital to hospital because they cannot be treated for the disease and end up spending just as much, if not more, than if they just took a trip to a center. But second, you spend less time in the hospital. We help more patients when we treat them more efficiently when we centralize all of our resources together. And it's also the necessity of scale. These rise exist because the government recognizes a demand for these services, that these people need them and have no alternative. Governments are very prudent with government funding because it's so scarce. So for there to be a rise, this signals that there must be a rising trend for more and more people suffering from specific illnesses that need these services. At the end of this, I point out that we do have to, in fact, morally have to save these individuals, and we're able to save them much cheaper on our side of the house. Their side says it's too expensive, let's not do anything. Second argument, on research and development, I point out this is so important. This serves as a signaling mechanism. You get more research because all the experts are concentrated in one area, but yeah, sure.
Why do you want to prioritize the minority of cases when this is about the rise, when the average person doesn't suffer from stage 4 lung cancer, but the beginning stages of
Yeah, I got it. So one, it's much easier to solve, so a local health center can take care of it. But two, you still at no point explain how you save these people who are the minority. Just because they're the minority doesn't mean we shouldn't care about them, panel. I think that's very easy. But I think that it serves as a signaling mechanism when you get all the experts to collaborate and work together and do peer reviews. Second, you build specific wings in these institutions for research. So at this point of the round, it's cheaper to buy a lot of things in bulk, which means it's significantly cheaper and easier to do mass testing and research on new chemicals. And there are also very context-dependent researches that we need to undertake. For example, a dengue wing that's in Muntinlupa, or a research institute on tropical diseases. You also get more money for investments. More people go into med school and go into these specific specialties because they know there's a demand for these specialties now. It's easier to centralize and leverage private-public partnerships like Novavax in the lung center of the Philippines. Why is it harder on Go when it's decentralized? Because you don't have the manpower to research because they're decentralized and cannot work together effectively. One, developing countries just have access to more research. This research is very important because a lot of it needs to be context-based, and the weighing of this is the access to alternatives. People who require specialized care are the most vulnerable because they don't have access to alternatives. If there's no hospital in your barangay, the next city with a hospital is likely to be very close. On our side of the house, we take care of the people who are most important. For all those reasons and more, I'm incredibly proud to oppose. Thanks.
Thank you for that speech, LO. To advance the round for side government DPM. You're here.
I'll just get water. This is my mug. I will get water with this mug. Okay. I'll just move that. There. POIs to chat. I'll start in 3, 2, 1. A country's first line of defense against epidemics is general care. Specialty centers might be able to treat niche and terminal diseases, but the inability of general hospitals to stop the progression of the common disease leaves them at the whims of nature at the risk of being overrun. I want to be very clear about what the Gov comparative does and why this is effectively able to reap the most of the benefits that Neil themselves illustrates from his speech. The first is that states themselves realistically will have some specialty centers on our side. This debate is about the rise, and we say that it is sufficient anyway. The first is to consider what a specialty center actually is. It's not just about treating the heart or treating the kidney, but they are specifically designed to treat the latest progressions of specific diseases and rarer diseases that people oftentimes do not encounter. And what that means is that the minority that we illustrate as early coming from Alyssa isn't a 5% of the population, but oftentimes is much smaller and oftentimes does not warrant the rise and the extent of resources that is diverted into this form of treatment. But the second is that the specific centers that are propped up by the state on our side are ones that are likely sufficiently equipped with treating these individuals. Because one, realistically, the average state doesn't construct a lung center if the most common of the rarest diseases that they encounter is one about heart disease or one about heart abnormalities. And what that means is that if the Philippines struggles with things like tuberculosis, that's why we have the lung center. If the Philippines struggles with things like heart abnormalities, that's why we have the heart center. They need to prove why that is so inefficient for the minority that they cater to. The individuals that do need the most specialized forms of care are those that have some ability to access that on our side. The urgency of this debate is not the minority that they cater to, but the vast majority of people that need general treatment and preventative care. People don't need highly specialized care because what plagues the developing world are the beginning stages of dengue, tuberculosis, that opposition allows to fester and rot and worsen. The rise is bad. Several reasons to consider here that were unresponded to coming from Neil. The first is that it is cost inefficient. The argument from Alyssa was not that it is expensive, guys. It is that for the resources and the budget that you do allocate to this rise and to this specialty equipment, you are able to treat less people. The point of a specialty center isn't to just buy x-rays or to just buy beds that any other hospital has. It is to specifically buy equipment that is highly specialized. It's not just an x-ray. It's medicine that specifically treats the worst abnormalities in your heart. It's not just a scalpel or a microscope, for example, but literal equipment that allows you to see the microstructures of your veins and your arteries. And what that means is two things. The first is that with the resources that have to be diverted into this niche equipment that is just empirically much more expensive and empirically harder to find, what that means is that the resources that the state diverts into these specialty hospitals are resources that just on net treat far less people. Not everyone is going to need this specific medicine. Not everyone is going to need this specific form of microscope, for example, to look at their body and whatnot. But the second is that there has to be a trade-off. And that trade-off that opposition has to take is that in spending your resources to buy this specialized equipment, it is a deprivation of the resources that would otherwise go into general equipment. So it's not that we have an x-ray and that they don't, but on extent, they might have one x-ray as opposed to having 5. It's not that they don't have beds, but instead of having beds for multiple people, they have to cut down on that in order to accommodate for the limited resources that they have on cost. The second problem is that this necessarily takes away from the construction and the development of treatment centers. And what they say is, oh, guys, it's only the excess budget of the DOH that goes into the specialty centers. Let's be clear. The way the rise occurs is for you to massively prioritize the specialty centers that they defend in opposition. And what that means is broadly two things. The first is that they necessarily do have to deprioritize the construction of things like general hospitals and general treatment centers, because necessarily the only way for you to massively fund even an individual specialty center is for you to take that away from other costs that come from the DOH. But the second is that realistically, you have to transfer significant amounts of manpower from general hospitals, from the clinics that they illustrate are sufficient in order to necessarily help these people. A few things here that they need to respond to. The first is that it generally leaves general care as especially understaffed. And what they say is that it's okay to trade off the people that have a simple cold. The problem is, it isn't a simple cold. It is the earliest earliest stages of the diseases that plague this country, that plague us with dengue, that plague us with TB, you can't just treat that in an average clinic, but more so, the clinic that they say is able to run on a skeleton staff is one that has to run with far less people if they have to be diverted to specialty centers. The second is that it is inefficient. Things like sanitation processes have to be less followed because of the extent of how understaffed these hospitals are, the extent of how little people are available to help. And what that means is that is when you exacerbate the risk of things like pandemics. That's when you exacerbate the things like cross-contamination and whatnot. But the third is that when you overrun general treatment, you also overrun specialty centers, because when diseases progress, when you can't treat that simple cold, when you can't stop it at a sore throat, that's when it develops to the worst excesses and the worst terminal diseases that they want to protect against. The problem is that if specialty centers are limited in the capacity that they can care for patients, the problem is that they have to care for far more than they're prepared to do on their side. Sure.
You are massively overblowing like the kinds of problems that these people face. If the problem is, aching or ubo, then obviously I'm pretty sure you can have antibiotics for that before it progresses into something worse.
Again, right, it's about extent. So maybe it is just aching or ubo. Those are people you can treat oftentimes, but it's not just aching or ubo. It's the dengue, it's the TB, it's the things that are empirically plaguing the developing world. It's not clear to me why a simple clinic is able to hedge against that. But the third is that the specialization that they want to prioritize is bad. Disease is unpredictable. We don't know if people will always have heart disease. We don't know if people will always be primarily plagued by lung cancer and whatnot. The problem is that in order for you to prop up specialty centers, you have to prop up specific specializations among medical professionals that leaves them vastly unequipped to deal with the unpredictable diseases that we cannot foreshadow and that we cannot see in this debate. I think it is a bad thing that people realistically cannot be prepared for diseases that we cannot control. But the last is the distance, and this is the comparative. Sure, the worst case on our side is you have to travel far to get to a specialty center, but that's okay. That's the minority of people. The comparative on theirs is that the average person has to go miles, has to do the same thing to get general treatment to stop a disease that could otherwise be stopped. We win because we show to you that the rise of specialty centers is one that is an active detriment to public health and one that jeopardizes the safety of the most vulnerable and the innocent and the weak.
Thank you for that speech, DPM. To extend the clash for side opposition, the yellow. Here.
Right. Let me just fix my paper. Wow. All right, great. Your voice. Be there. All right. Starting in 3, 2, and 1. The reason why government is losing at the end of DPM is because they are massively flippant about the types of problems that people face at certain points in time. Sure, if they want to assert that the problem is TB and dengue, the point is, obviously these are very tackleable very early on in the disease. If you have ubo, then obviously you can take an antibiotic. If, for example, you have mild pneumonia, then obviously a general practitioner can probably take care of that. But if they want to talk about late-stage dengue or late-stage tuberculosis, that is obviously, in their words, the vast minority of cases that requires things like specialty care. And insofar as their model is literally, we will have less of this or we will have it spread out, then it's very unclear to me how they overcome the problems we explained coming from LO. That is, it is not that you are not going to have access to it. It's that on their side of the house, if you have access to a smaller specialty center, there's a chance that there's a complication that isn't going to be addressed, there's a chance that these people probably won't have the ability to treat you. And that's the point at which you get bounced from hospital to hospital, exasperatingly increasing the cost on their side of the house. But if they say we don't know when people will complicate, clearly that's tackled under our side as well. the first thing I'll talk about is what is the comparative. Because the way that they try to sneak in this debate is to say, well, centers will exist anyway for the most pervasive diseases. You get this from PM and DPM. Problem, this is status quo, guys, and PO puts it brilliantly. If states need certain diseases, then they would prioritize those. That's why you don't have the migraine center of the Philippines. You have the lung center of the Philippines because the Philippines is consumed by smoke. You have the kidney center, NKTI, because obviously you have a very big problem of sodium and things like, malnutrition in the Philippines. Obviously, the kinds of centers that are raised in the rise are the ones that are obviously prioritized for a developing country. I don't know why we make unnecessary centers under our side, especially when we explain there's a large amount of political will needed to even justify a very huge cost as this. Secondly, then, on access, what do we hear from them? The first thing that we hear from them is that it's less cost effective because they treat less people. One, this assumes such an extreme amount of doctors. Insofar as we're talking about government institutes that obviously have to go through things like bureaucracy, like red tape, it is very obvious that you probably need to screen whether you do actually need a certain extent of doctors. It is very unlikely that you'll have doctors doing nothing in these centers. And therefore, even if it's a large cost, clearly it's an equilibrium. And therefore, it's unclear to me why we're overspending under our side. Secondly, even if doctors aren't treating people, they do not respond to the whole thing about research and development. Unresponded to, and therefore government has so much work to do. And therefore, given that we explain that this is valuable, I'm going to rebuild it later, but clearly they're already losing. The second claim that we hear is the cost is high. One, if government agrees that these are the minority of people, it is unclear why they will spend too much on it. Like, yeah, we'll have a more expensive x-ray machine or something. Like, that's obviously one x-ray machine needed because not everyone is going to go to the NKTI, and therefore it's unclear to me why you're going to spend so much on something that's never going to be used. Secondly, if their comparative on Gov is, we will have specialty wings, and this is, in versus words, the biggest kill, the economies of scale we explain at LO kicks in. Because if their response is, we will have it spread out, it is far cheaper to have it in one centralized area because it's things like transaction costs, it's things like transportation costs, it's things like being able to maintain several different areas, which means that the ability to spend on these multiple areas increases dramatically. Versus under our side of the house, it's far cheaper to maintain. What we explain, therefore, is, and this is exclusive material from me, why is it likely that you'll have a baseline level of general care? Note this is repeating for Gov. Three things. One, our analysis on economies of scale means that the total cost is lower under our side, and therefore, obviously, the extra cost in the DOH budget goes to these kinds of centers. Obviously, this is outside the general budget placed for general practitioners. This is just explaining why we have much more of it under our side compared to theirs. Secondly, there is a government interest to unlock people and make sure that people are able to work because this is the priority of developing countries, i.e. economy, which means that you don't want them to develop and snowball sicknesses. So the nuance is, most people's problems start out as coughs or colds, even if they want to say, oh, it's tuberculosis or cancer. But so definitely there is a capacity there. If we explain that usually people just need antibiotics or probably just need some sort of help there. But thirdly, even if you don't believe that some people can't access these things, it is likely not exclusive as a problem. Why? Because despite all of the political will reasons I just explained, the people that the state does not care about enough to give literally any care probably won't get a hospital near enough on their side anyway, and therefore it's unclear to me why this is so exclusive. What that means is, sure, we might not have 10-story hospitals, but clearly have things like a barangay health center that probably has enough in terms of their pharmacy, probably has enough in terms of being able to address the baseline problems there. But even at the very, very worst case, we are fine with explaining that this is less important. Two reasons why. One, because it's much easier to solve. The most common problems are not heart attacks and cancer. PM is wrong. It is coughs and colds. Yes, they are the earliest signs of more major diseases, but the fact we can quell them early on means that it's probably not a problem that we need to cater to under our side. But second, if there is a trade-off, at worst, the reason as to why we have to prioritize these people less is because they can survive much longer without any excess help. Versus under our side, someone's literally dying because of cancer. I don't know why you can treat them on their side if you wait. Before that point, go.
The people with the most terminal and worst excesses of the diseases you want to treat are people that also can't access the treatment just because of their location, for example, just because they're poor.
Yeah, I got it.
Just
Yeah,
because
I'm done. Yeah, you can stop. You can stop. Yeah, you can stop. If the problem is distance, we already explained why that is probably not exclusive if the state really does not care about them. But you have literally no response as to why it is more expensive. If it is in the case that in the quality of healthcare, they don't get the adequate amount and they have to go to another hospital because your specialty wings are just not that good. What did we explain in terms of quality of specialty healthcare. Our question to Gov was, what then about the people who do need this very high extent of healthcare? They say, well, we'll have some specialty wings, but you have to gut check if these are good enough, right? Because if they're spreading out like literally in the entire country, and you are using the funds of one singular building, what are you gonna do? Give them a 1/100th of a building in each barangay? Like, be real, guys. It's not a substitute for building. What we explained in terms of why it's worse on Gov is, obviously, in individual hospitals, the funding is heavily diluted. You have things like less expertise and less people who are experts at that specific thing, which means that obviously, if you don't know, one doctor might know one complication, another doctor might know another, and it's under our side where all of them are present in the same place. Versus on their side, if there's a complication and the doctor doesn't know about it because obviously it's very niche, then it becomes far worse. But the second reason why it's better is it serves as a blueprint for all other hospitals. This is important because of irreversibility. They have no response to research and development. I'll just rebuild it now. We said you develop solutions because of the absolute centralization of the ability for doctors to research all at the same time. That's why we know how to solve different forms of complications. And the reason why that is true is because obviously the labs are centralized. On their side of the house, people often don't submit data because it's just too far flung, or people just don't have the ability to send that data in. And the reason why that's important and debate winning for us is because it's top down. This is what prevents most of the problems on their side. That's why most people don't get tuberculosis anymore. That's why people are able to solve things like, cancer early on, because we're able to solve problems that are nuanced to developing countries, and therefore it's precursor and preemptive to all of the problems they face. GovWhip, you have so much work to do. Good luck to you.
Okay, for a bit here.
I'm assuming I'm both audible and visible.
Yes.
Thank you. Taking shots. Healthcare systems have long felt the epidemic of poor budget allocations, and this is most especially important in developing countries, where the most pervasive problems with regards to healthcare are rooted with the lack of general healthcare systems in status quo. On Gov, we prioritize these people. On Op, you cater to an arbitrary minority that they never prove to heal. The first thing I want to do is to clear out what the margin of this debate truly is and to dispute the pivot at David. The first thing they explain is on the instances where this rise necessitates. They explain that apparently when the rise is apparent and when the rise happens on status quo, that more of these general healthcare systems will probably not be disregarded. The problem is quite simple. A rise necessitates that when systems are already sufficient, the excess of these things come to life, come to proliferate. So yeah, even in the instances that health centers or, for example, heart centers might exist, the excess of this is what is necessitated from the rise. It is things such as the lung center, kidney center that might not be the most nuanced to countries like Thailand or the Philippines, but are also still existent, and that is necessitated with the rise. The only response they say to this is to say that, in terms of economies of scale, at the point in which people will still need general health, you'd still probably cater to these individuals. Again, the comparative was quite clear. When you prioritize the infrastructure of more and more specialty health systems, at the point in which you prioritize more specialty nurses, for example, or more general education with regards to kidneys or with regards to other specific organs, you take away from the active measures that developing countries do already have limited fundings to do so. The second thing they explain is that common colds and stuff like these are oftentimes tackleable, and these are just antibiotics and you can just easily disprove them. The problem again is that the rise takes away from things that we can hope to prevent these. We explained quite clearly from Alyssa that the common colds that you face on our side of the house are oftentimes in developing countries severely disregarded precisely because there's a lack of efficient funding allocation. The way in here is quite simple. Sure, they might heal another person with antibiotics. That might be 2 or 3 individuals that can help in the ICU. The problem on our side, we are at least able to heal more individuals, to prioritize more individuals within that scale, and on numbers and on mass, they are just generally left to heal lesser individuals. They don't engage at all with this comparative, and that is why they lose. The first discussion I want to attack is this qualm on the most vulnerable patients. They explain that apparently these individuals still matter, and at the point in which the rise is necessitated, you're able to help them the best. The problem again is that oftentimes these cases are the smallest of the smallest minorities. Not everyone is born with a deformed heart, but everyone is subject to the same types of typical colds that oftentimes snowball into the worst forms of tuberculosis or the worst forms of dengue or malaria that are oftentimes unchecked precisely because of the lack of funding, or precisely because of the literal, like the way in which we don't know what to prioritize in status quo. The second is they just don't explain why, for example, the person who has several heart diseases won't be healed on our side as well. The comparative was quite clear. There will still be specialty hospitals. There will still be hospitals that tend toward, for example, specific organs if that's what they so protect. But even in the instances that there aren't, we explained that en masse, we are able to protect at least the most vulnerable. We are able to protect more individuals at a point in which the rise does not exist. The third qualm they explain for vulnerable patients is apparently research and development happens better on their side of the house. Again, this abhorrently disregards the status quo that we're debating on developing countries who oftentimes do not have infinite resources for research and development. But secondly, this is just technically wrong, right? Oftentimes, a lot of these centers don't necessitate research. They don't start off research precisely because they're developing countries. They're not conducted within these instances. The fourth thing they explained is on quality. Again, the problem with this is that you might get more and more institutes for hearts, more and more institutes for specialty centers, but they do not necessarily prove as to why the most number of individuals are benefited from this model. At the end of this discussion, it's quite clear. They never really prove as to why the most minority of cases are ought to be the most prioritized. What we clearly explained is that the individuals, the problems within the healthcare system in the status quo right now is where individuals are not attended to because of the lack of general care on our side, on their side of the house. The next discussion then is on resource prioritization, and especially the most important issue on the debate. The first thing we explained from government is that the vast majority of individuals in developing countries suffer from the baseline bare lack of basic healthcare. So it's young kids from San Isidro who can take 3 jeepneys to the nearest hospital to treat the fevers in the capital city precisely because there's little to no basic healthcare resources. It is the people who do not have proper advisors on things such as nutrition, such as dental health, such as proper hygiene that oftentimes snowball into greater diseases in the future. It is old individuals who need maintenance medications but cannot access it precisely because the rise necessitates a deviance of these things. It is preparations for things such as COVID-19, for endemics, for monkeypox, and all of these things that general healthcare oftentimes prioritizes. On the comparative, when there's a rise and a greater priority for specialty centers, you greatly deprioritize all of these things that oftentimes the majority of individuals face within the daily status quo. And this also applies within the context of developing countries. By virtue of these processes and specialty centers, oftentimes they are the most niche, they're most complicated, they oftentimes already lack in resources. Therefore, at the point in which you establish all of these specialty centers, it's unclear as to why the quality of treatment that you get is something that's even better. Or compare this to our side, where at least the individuals are treated at least to a significantly greater degree, and that is why on resource prioritization we already win. Before you explain how does this change the way you should view the debate, sure.
We explained that there is an incentive for governments to make sure that people are healed, which means that if they have no healthcare under our side, that probably means that the government does not care about them at all, and therefore it's uncomparative for you to say that this only exists in opposition.
Again, notice that this is a rise debate. When systems that are already sufficient necessitate a rise, means that there is an existence of excess, for example, institutions, excess things, excess processes that oftentimes are not necessarily great or not necessarily less than what we have on our side of the house. So yeah, economies of scale might work, but the fact that you deprioritize all of these things for specialized centers that we already explained is oftentimes niche and do not affect the greater number of individuals, that is where you lose. So yeah, maybe the government will care, but the way in which they allocate these resources to care doesn't necessarily greatly affect the extent of which these individuals are most affected. How does this change the way you should view the debate? The first is quite clearly on weighing. The way in which they allocate the resources on their side is very bad. We explained that the perverse problems that oftentimes come with developing countries are the individuals who suffer from the most basic forms of colds, most basic forms of sicknesses that oftentimes snowball because of the fact that they do not have basic healthcare in need. With that in mind, it's quite clear that on our side of the house, absent this rise, there's a greater priority and there's a greater will for these institutions for basic healthcare to be prioritized and to be better improved. We cater to the most vulnerable. They don't explain why these people on their side of the house will be healed.
Thank you for that speech, Govip, to end the clash for side opposition uplift. You're here.
So I will take you guys to chat. My pronouns are she, her. Okay. The first thing I want to tackle is just this clash. Should we prioritize a scale of more people or should we prioritize more vulnerable people? The first thing we hear coming from Melissa is to say that, oh, these diseases are niche, only a few people will need it. The first response to this is a context that came up from Neil that went largely unresponded, which is just understanding the context of why the rise exists in the first place. We told you from Neil that the rise indicates a rising demand, right? That the fact that this country, like if the country recognizes a need for these kinds of things to be specialized, it suggests to us that there is a rising demand for these kinds of complex complications existing and therefore more complex healthcare that needs to be accessed, right? They don't actually give to us a counter context for why this rise exists. They only tell us that this rise indicates that it's excessive. I don't know, number one, like we explain why many people likely already need a lot of these complex services like the health center or the lung center. They don't explain why it's excessive. Like if it's true that it is excessive, they don't explain why it is that states overspend if it is true that nobody uses. So if it's true, or if you can't believe the context that just no one is using these things or these things are niche, then it shows that the scale of people who are likely to be treated is likely inexclusive. Because I don't know why it's true that these people are the minority in the first place. And this like first response is incredibly important because a lot of their case is contingent on not a lot of people using it. Things like, oh, the equipment goes untouched, or all of these other problems. These things are contingent on a context that they don't prove. The second thing or the response I want to launch is that even if we get them on their best case, that maybe it is niche, we know it's still largely more important versus having access to general health. Why? Because the fact that these things are easier to cure on government means that you just generally have more access to alternatives and medicines that would help you treat it in the first place, right? We gave to you many reasons as to why like general health hospitals are likely to exist. Like even if you listen to the reasons from government, the fact that it affects like a majority of people, the fact that there's a rising demand, the fact that there's a government interest to unlock these people or to ensure that these people are able to treat these sicknesses such that they don't develop and snowball into things that are worse, right? We posit you that having a hospital in every barangay is less important than just ensuring that they can access something, right? The reason why opposition wins this point is because the point at which people have some kind of access to some hospitals, we already win. Because sure, maybe there's no hospital in your barangay, but it's significantly easier and much closer for you to access the next hospital that would be able to treat you. This is how we weigh, right? Because the worst case on our side is that some people might have to travel to another city, or maybe their cough gets marginally worse. The worst case on government is that people with complex heart diseases are actively going to die. But even their best case, let's say they do get some kind of treatment for their cough. If the cough is indicative of a more complex issue, they still die on government because it's harder for them to access things like more complex healthcare, right? The next thing I want to explain under this issue is just explaining to you why minority and the scale is a less important weighing metric. The first thing under this is just that minority and like scale is a very abhorrent weighing metric. Like if you look at other minorities that exist, ethnic minorities, indigenous people, religious minorities, you being a numerical minority does not justify letting you die, right? But we would rather flip this. The fact that minority people need it, the minority of people need this, means that there needs to be more advocacy for these kinds of things existing. absolute rise. It means these people have access to no treatment. It means these people lack the amount of research that they would have needed to treat their different kinds of sicknesses, right? So it means they have less info on things to properly diagnose, less info on things of where this disease comes from and how to treat it, right? We tell you, and we tell you on our side, we have inertia, and this unlocks a specific problem that you see on government bench, right? Because on government, you are prioritizing people whose hospitals will always exist because of the constant demand that they explain. The problem in government is that they don't have inertia to have more specialty centers for those who actually need it. It's harder for an individual to advocate a general hospital, to obtain a special heart specialist, or obtain like complex and expensive equipment if it's just you who needs it. Versus on our side, when we group together everyone who needs it, it becomes significantly cheaper for you to access these kinds of things, right? This is important because many diseases are unique to the context and environment of developing countries to exist in, right? The only thing they tell us is that, oh, well, we can have research and development centers in our side as well. The problem is that the problem is that they can't just get research from developing countries because a lot of these things are things you cannot access from developing countries. The fact that a lot of these things are unique to the environment and unique to the Philippines means you can't. It's much harder for you to obtain this by just like relying on like Europe or America to give you specific research on diseases that are unique to your country, right? This is why we win, even if you believe our worst case that these kinds of things are excessive and not enough people are filling up these heart centers or whatever. The fact that these like the increase in these heart centers leads to more research and development for these kinds of different sicknesses, makes it more available, and therefore, at the very least, ensures that some people get access to the kinds of help that they need. The next thing I want to discuss is that on cost, right? The first thing here under this is you have to travel far. Okay, before I move on, let's take the POI.
You concede from Neil that these centers still treat a relatively small minority of patients. Perhaps the rise is not a reflection of demand, but a reflection of other things like political interests and optics that come from people.
Number one, we didn't concede it. That's an even if. But number two, you don't prove these political incentives. What's the political incentive to create an empty hospital where people are understaffed, right? It's unclear, and I think it's quite too late to do anything from Reply to fix that, right? So given them cost, first thing we hear is that they have to travel far. Number one, I think ensuring people get help is largely more important because at the very least, if you need specialized care, you have a direction of you knowing where to go. Versus the comparative on government, if you need access to specialized care, you're forced to jump between different hospitals because you don't know which ones have access to the kinds of materials, equipment, or expertise that you would need to actually help you, right? But secondly, in terms of general health, even in our worst case, maybe you have to travel to a different city to access general health. That's an additional marginal cost that's incredibly small. So on that, people who need help generally spend a lot less on our side versus on their side. The next thing to say is equipment is expensive. It's symmetric because they're going to need to buy this equipment unless they want these people with heart diseases to die. But we explain to you that economies of scale makes this equipment largely cheaper, right? We explain to you that on our side, like because these people like economy of scale just generally makes it much cheaper to buy because all of these things are already in one area, right? The next thing we say is that you take away funding from other hospitals. I don't know why this is true. Like presumably there are other reasons to fund hospitals anyway, so I don't know why all the funding has to come from this specific thing. But we pushed you coming from Neil that if it's true and it is an excess, then the excess money that did not go to these specialized centers can just go back into general health anyway, right? But also there's other incentive and other actors who are likely going to invest in these things anyway, right? The last thing they say under this is that you're likely going to be turned away if these hospitals are full. That's much worse on your side when you have less of these hospitals. On our side, the heart center, like you being turned away from the heart center, is a less harm because there are other heart centers that exist or other specialized care. The last thing I want to talk about then is lastly just on doctors. So the first thing they say is that doctors are less flexible. I don't know why this is a harm. Most doctors are specialized and therefore are not flexible. I also think doctors probably shouldn't be flexible because the more expertise, like the more specific you are to the specific thing you're treating, the better the treatment you're able to give, the better expertise, and therefore the better quality treatment is accessible for people, right? And the last thing they say is that doctors are understaffed. Again, asserted, I don't know why it's true, but coming from Neil, we explained to you that there's a signaling mechanism. So if governments are explicitly putting more investment into healthcare and specialized centers, then more people are going to opt into being doctors. Even if you don't credit this response, you still can't believe government that there's going to be an understaffing because they also just don't prove why this is true. All of this to make it quite clear, opposition wins. Thank you.
All right, to add the keys for side up reply here.
I think the biggest win in the round is I don't sound like I'm in a fishbowl anymore. Okay, sige. Let's start number. Starting in 3, 2, 1. And go. From the start, government's case was built on sand. The only thing that stands from their case is to say, opposition has to defend an excess of specialty hospitals. This is a cheesing of the motion and is honestly just a spit in the face of the cap who made this. What is the problem here? Government does not explain why the rise equates to an excess. This is asserted. Why is it that the rise is not in excess? What are the reasons we provided? One, it requires large amounts of justification because of bureaucracy, and therefore it's very unlikely that you will overspend because you have to justify all of the costs. Secondly, Pio says it himself. States only have specific endemic certain diseases such that if it is the case that you are making a specialty center, that probably is indicative of a very big demand or very big urgency to make that center. So yeah, the rise means that you are making NKTI, you are making Lung Center of the Philippines, and on their side, you don't have that rise and you aren't responding to that demand. So if it falls down to you making us lose because of this asserted counterfactual, I'm fine with losing at quarterfinals for that. The second thing is on common illnesses. Their only claim here is to say, well, illnesses can snowball even if it's small. One, them conceding by the end of the debate that it is small means that it's easier to solve, and therefore our counterfactual, which was explained down the bench, sufficiently deals with this. The fact that you can just go to a general practitioner, the fact you can just go to a general pharmacist, the fact that you can just get antibiotics. But secondly, we at the end of the debate were fine with taking that trade-off. Why? Because the worst case in our side of the house, maybe someone with a cough probably, gets a worse cough after like a week. That's fine. But the person who does not have access to proper medical care on their side literally dies. Obviously, the extent is just far worse on their side. Clearly, if it's in terms of common illnesses, what we also explained down the bench, especially from the deputy's speech, was specifically why you would have a baseline level of healthcare or general care. Because of the fact of economies of scale, even if we don't believe that, we explained that governments do have an interest to economically unlock people, and that often is intertwined with being able to have a baseline level of healthcare in every locale. So yeah, we won't have hospitals. At the very least, you can just agree that we probably will take care of these people if their problem is literally just the first onset of, TB, which obviously you can probably solve just from the onset because these symptoms are very, very small. Clearly, in common illnesses, government does such little effort to explain why this is so significant of a margin. We do so much effort to explain why it's not. Secondly, then, this is the much larger thing on specialty illnesses. Their only response to cheese this out of the round is to say that we have multiple specialty illness wings in hospitals. One, they never analyze feasibility. NKTI, guys, is one building. The Lung Center of the Philippines is one building. Heart Center of the Philippines is one building. Their counterfactual requires you to believe that you are splitting all of this resource in one single building across hundreds of thousands of hospitals in the Philippines. Hello, obviously you needed to analyze this just far greater than that. Secondly, we explained the importance of the scale, because what if there is a complication and the doctor that is assigned to your hospital doesn't know how to solve it? Or quite simply, the fact that it takes much longer to solve under your side because less people are working on each individual patient, especially when both teams end up conceding that these individuals are very, very, terminal, or very, very, precarious and need as much attention as possible for it snowballs even further. In terms of specialty illnesses, clearly, we were the only one who analyzed feasibility on that. Lastly, on research. I understand I didn't rebuild it that much from the deputy. We explained it very sufficiently coming from Matcha as the rebuild. But I want to highlight the only response we got coming from GovWhip, which is the only response Gov gives. Their only response is they don't research because they are developing countries. That is untrue because we preempted this coming from Neil. It is a fact that, of course, they research when they're developing countries, because even if they are developing countries, you cannot rely on Europe and America because oftentimes the way that these diseases manifest are very specific to your locale. It is a fact that smoke in the Philippines is, very specific to the, realities of the Philippines, and therefore you need the researchers in the Lung Center, which means that all of the solutions to all of these, the fact that we had partnerships with Novavax, the fact that we were able to make, certain, domestic specific solutions for things like tuberculosis exist under our side because of research. No response from them. No matter which issue you wanted to take it on, we won on all of them. That's why we'll see you tomorrow.
Thank you for that speech of reply to end the clash for side Gov reply. Here.